who is well, OBGYN, right? Or
Yep, and maternal fetal medicine.
oh, cool. So I'm gonna give it to her so you can introduce yourself and then we can take it from there.
Sounds good. And thank you everybody for coming. Hopefully I'll be able to give all of you just a little bit of insight into some of the different medical subspecialties in OBGYN, in particular, what I do. So I am in my 4th year as a professor at the University of Minnesota. And I practice maternal fetal medicine, which is a subspecialty of obstetrics and gynecology. So sort of how I got to this point, you finish medical school. I then did a 4-year residency in obstetrics and gynecology. So kind of broad spectrum, everything related to reproductive health. That was 4 years. And then after that, I did a 3-year fellowship in maternal fetal medicine. So maternal fetal medicine, sort of in a nutshell, is taking care of high-risk pregnancies. So either people who have health issues that complicate their pregnancy, people that have problems on ultrasound, so some issue with their pregnancy that needs to be attended to, and the intersection of all of those things as well. So, people who've had horrible pregnancy history in the past who want to get pregnant, people who have serious medical issues who are trying to become pregnant. So that was a 3-year fellowship that I did as well. So 7 years after medical school, which seems like a lot, and it kind of is, but then I actually chose to pursue 2 years ago further training in addiction medicine. So my clinical focus now is on perinatal substance use disorders. So I can talk a little bit more about that as we move forward, but I really look at the intersection of reproductive health and addiction medicine. This is just a little part of what I do. The majority of my job at the university is providing clinical care for all kinds of high-risk pregnancies, and then teaching the residents, medical students, having people shadow me before. So we were talking before we started a little bit about how we used to have undergrads who would sort of come in and really get to see what we did. I also do a lot of clinical research and then education throughout the Midwest, mostly related to perinatal substance use and breaking down stigma just in our general communities and educating providers. So that's sort of a little introduction to who I am. And then I'm happy to go into further detail about how I got here, or kind of what my day looks like, or whatever would be most helpful to all of you. And thank you so much for inviting me here today.
Thank you so much for the introduction. You guys can enter your questions in the chat or feel free to unmute yourselves and ask. But I can start off with one. I think you're the first OBGYN we've had. What kind of drew you to the field and really kind of motivated you to go into even more specialized training?
Yeah, great question. So I was actually one of those people who had no idea what I wanted to do when I went to medical school, except I knew I didn't want to do OBGYN. It just didn't seem like something that I would want to do. I don't know why. I don't have a specific reason. And then I had the opportunity. So I went to medical school in Milwaukee, Wisconsin, and I had the opportunity to do my clinical rotation at one of the busiest hospitals in the state, which was in downtown Milwaukee. And I remember being at the first delivery that I did, and it was just such an amazing experience. And then to sit and listen to these physicians talk about, this patient has this complication and this thing is going on with the baby, and just trying to balance, two sometimes opposing interests. And I just found it on an intellectual level really fascinating, and just loved it. And so I ended up choosing it a little bit later. And I guess the message I have for that for all of you is, when you go to medical school, or if you're entering kind of a medical field, keep your eyes open and enjoy every single rotation. Because I went into this thinking, well, I'm going to do this. It's a requirement for my medical school graduation, and just thought, wow, how did I never find this interesting? And it's just so amazing to get to share that journey with pregnant people, or recently pregnant people, or people who aren't pregnant at all. It's just a really amazing process to get to be invited into. When I did my residency, same kind of thing. I thought, okay, I love obstetrics and gynecology. This is really interesting. And I did my first maternal fetal medicine rotation, and again was drawn to sort of this kind of what we were talking a little bit about ahead of time is, you take a problem, you take the science that you know, and then you take that problem as an individual person, and how can you best balance what's going to work the best for them based on the data that you have, because patients don't read the textbooks. They don't come in with like, yes, I have just this high blood pressure problem in pregnancy and you're going to manage it. They also have, diabetes, or they also have a baby with a heart condition that the timing of delivery will matter. And so I was really drawn to that ongoing discussion about how to individualize care. And when you do maternal fetal medicine, you get to do a lot of different specialties melded into one. So you get internal medicine because you're managing maternal chronic health conditions like diabetes, hypertension, lupus. So you've got that component. Then you've got the ultrasound component. So we do ultrasounds for pregnancy, and we also do procedures related to ultrasound. So there are a lot of cool interventional radiology type things that maternal fetal medicine doctors do that none of you may be aware of. And some of those are amniocentesis, which is sampling the fluid around the baby in the bag of water to look for genetic conditions, to look for other infections, other issues with the baby. There are some even further subspecialized maternal fetal medicines that are what are called fetal surgeons. So we can actually give a baby a blood transfusion while it's still inside if it has this condition called hemolytic disease of the fetus, where it has very low blood count due to an interaction between the mom and the baby. It's called isoimmunization. So I have partners who do blood transfusions on a baby while it's still inside, which is pretty amazing. I have partners who put shunts in babies. So if a baby has a fluid collection in its lung or a extra fluid in its bladder and it's not draining, they will do those types of things. And I don't have that extra specialization, but I get to participate in those. So it's radiology, interventional radiology, fetal surgery, internal medicine, and also you still get to be an obstetrician with a little bit of gynecology sprinkled in. So it's just this way to always have something different to do. And I think I'm someone who's not drawn by the same protocol every day. So I never know coming into clinic, what am I going to see today? And sometimes that's stressful when you have this perfectly planned day and a new patient comes in with a devastating diagnosis and you have to sit with them and go over that. But it's exciting. And I like that excitement in the subspecialty.
A question from Jennifer was, what was the most challenging part of medical school and residency for you?
Oh, yeah, that's a really good question. I think the thing that was the most challenging for me was the lack of focus on self-care. And I think we're seeing that a lot now in just so much of the trauma that a lot of healthcare providers are experiencing in the pandemic. So many of us never set up a good regimen for self-care. I certainly didn't in medical school. I absolutely didn't in residency. When I did my residency, there were no hour restrictions. And so we would work up to 100 hours a week on the GYN oncology rotation. I was one of the first people to be very happy when they changed that. But even now, and especially for those of you who aren't in medical school, to think about, you only can work 80 hours a week. Okay, that's twice a full-time job. And you're definitely not getting paid twice a full-time job. So I think that I wish what I would have done is found better ways to balance my self-care and also advocated with my teachers, my mentors, the faculty, about making a priority for self-care. Now, I know that's something that a lot of medical schools do now. Our residency here for OBGYN has resident health days. So they'll take days where they'll do, mindfulness meditation, or they'll have a yoga class, or they'll just go outside for, some sort of hike or something. And I think that making priority for that, making priority for your own just sort of preventative health care. So I definitely did not go to the dentist twice a year in medical school and residency. And I now work at an institution where essentially how it works in academic medicine is you have certain days where you have clinic and certain days where you do academic stuff. And we can talk a little bit more about that. But at the university, you can take your regular time to go to the doctor. So it's not like you have to take a sick day to go have a mammogram or to take your kid to get their vaccinations. You can do those things as part of the day, and they prioritize that. And when I was in residency in medical school, you didn't have those opportunities. So definitely self-care was very challenging for me. I think I can move on. Do you want me to go on to the next question?
It's up to you, yeah, of course. If you want.
Sure. So I see that Nicole said, what was your pathway to medical school? Did you know all along that you wanted to go into medicine? So I grew up in a family with really nobody was in healthcare. I had a nurse, an aunt who was a nurse, but I didn't really know much about what she did. And we did have some family members with chronic illness who would have to go to the doctor a lot. And I just found that very interesting, but I didn't really necessarily know that it was something I could do. And didn't really have access to a lot of the tools that would allow me to get that exposure ahead of time. So I found it interesting, but didn't really know what I wanted to do. Kind of went into undergrad as a anthropology major and a French major, and just kind of floating along and trying to figure it out, but taking all the science classes because the science stuff was really interesting to me. And so it was a little bit later for me. I guess not later. I was able to go into medical school after 4.5 years of college. So I had to take summer school, both in between my 3rd and 4th year of undergrad, and then in the summer, including like up to a day before I started medical school, to get all of the coursework that I would need. So I did kind of go right from undergrad into medical school. The things that I kind of wish I would have had along the way was to know to reach out to somebody at the medical school, when I was in Wisconsin, or an advisor, and just say, hey, I don't know anything about this process. How do you get in? What kind of things are better to do? And especially because medical school is hard to get into. What things can I do to position myself? Likewise, once you get into medical school, once you know what you want to do, or if you just say, I think I want to be in medicine, or I get to work at a university, I get to do research, I get to teach. Finding somebody who can help you get positioned for that type of thing, because I just sort of stumbled along. And so I have taken it upon myself, if I mentored a high school student here in Minnesota last year, right before the pandemic, so I guess about 1.5 years ago, who's very interested in going to medical school. And just, she reached out to me and was like, hey, I'm interested in doing this mentoring program through our high school with you. And she worked with me for 6 months, and we kind of talked through, hey, if you want to go to any kind of graduate school, here's the kind of things you should do as a first-year undergrad. Here's the kind of things, and let me help you find a project as a high school student so that you can go in to med school and say, way back in high school, I helped create this algorithm for managing opioid use disorder when people come in withdrawal and pregnancy. And it wasn't a huge project, but it was very helpful. And so I think finding people who can help you, even if they're not a person who will have those connections, but either has that lived experience of getting through medical training, who can say, these are the types of things that are going to help you, that you won't, there isn't like a checklist you can go online that says, do this research in this year, be involved in these groups. And that's not to say that there aren't non-traditional ways to go about these things, but I think there are some things that I would rather people not have to learn along the way, that are simple information that we can provide. I think some of the biggest things are getting involved in some sort of research. So I've had, an undergrad student who reached out and said, hey, I want to work with you on a project that you're doing. And we got, them trained in kind of the confidentiality of medical school and how to access the medical record. And then they just assisted us with data input, but then had their name on, a great project that they have participated on. And whether that person goes into medical school or some other graduate school, and certainly not, they don't have to go into OB, they have that record of like trying to learn some of that stuff. And I think reaching out just to somebody at your school that can assist with that is really helpful.
Another question we get common is that we have pre-PA and NP students who also join, and sometimes they're curious on how the doctor relationship with the PA and NP works, and like how does their responsibilities go with yours, and how does this relationship work all together?
Yeah, and I think that a highly functioning medical team involves all of those disciplines. And so, for example, I can give a couple of examples of how that fits into OBGYN. So in my clinic, we have patients who have extremely complicated pregnancies, either mom or baby issues, that need to be seen by us for all of their regular pregnancy care. And we have a nurse midwife right now. We've had a nurse practitioner in the past who is part of our team and will actually see these patients for their pregnancy visits. So a patient comes in for her first visit with us. the nurse midwife and I will go in and see her together and talk about, here are the issues that are going to be a problem for the pregnancy. But then she provides more of a wraparound care model for the patient. So if someone's really high risk in their pregnancy, you don't want to over medicalize that. You still want to give them a good birth and pregnancy experience. So our midwife will sort of allow them to still be sort of a regular pregnant person, but also collaborating with us so that if something more complex happens, she'll rope me in to sort of assist with that. In my prior training on the GYN oncology team, so that's cancers related specifically to the reproductive tract, we had a nurse practitioner who was on the unit with us. So we would, when the patients were admitted, she would be there to admit them, and she would do some of the work alongside us. So she wouldn't be the one doing the surgery, but she got to assist with the surgeries, and she got to help care for the patients after delivery, and functioned very independently in that role, and was also great because she would train the new residents. So she wasn't just doing a clinical job, she was getting to teach as well. So I think there are a lot of opportunities for nurse practitioners and physician assistants in obstetrics and gynecology, doing prenatal care, doing preventative women's health. We have a shortage of OBGYNs in most places in the country. And so having other medical experts who can provide some of that care alongside us, I think is really valuable.
Yeah, you talked about having a lot of diversity kind of in your job, from like research to clinic to all these different types of things. What does like a typical week kind of look like with being in clinic versus research or teaching?
Yeah, that's a great question. And I'll kind of go over what my month looks like, because essentially what I do is I have 3 weeks of sort of standard time, and then I have a week of service. So my standard time on a typical week, I will have 3 full days. So usually from about 7:30 to 4:30, I'll be at one of our clinics, and our team goes to 6 different clinics in the Twin Cities area. All of them are affiliated with different hospitals, so they're all kind of attached to a hospital. So on that day, I will see about 25 patients. The overwhelming majority of them will have some sort of ultrasound related to their pregnancy. And then I'll have a couple of other patients who are coming in either for what's called a preconception consult. So they want to get pregnant, but their regular doctor's like, I don't know, it seems like it might be risky for you. Let's talk through what's going to happen. And others that might be just coming in for pregnancy care. So they're one of our patients and they're going to deliver with us. But most of my patients have an ultrasound that's tied to their clinical care. So about 3 days of the week, I do that. The other 2 days are what are called arts time. So that's sort of our academic time here. That stands for academics, research, teaching, and service. And so those are the days I'll be giving a Zoom talk to our residents, or I'll be meeting with somebody on a grant that we're submitting for some sort of research related to the work that I do. A lot of times it's service work. So I do a lot of unpaid volunteer work that I'm allowed to do on my time because it's valuable for the university and it's valuable for the community as a whole. So I recently finished up being co-chair of the Maternal Mortality Review Committee, which is looking at all of the deaths of people who were recently pregnant in Minnesota and trying to figure out ways to reduce the risk. Do we see a pattern in who's dying and why they're dying, and can we fix that? So those 2 days, it's kind of a mix of things. Then 1 week a month, I do what's called a service week. And so if patients are very sick in their pregnancy, but not sick enough they need to be delivered, they'll be admitted to what's called our antepartum service. And so essentially, for 7 days in a row, I am on call for pager, but then I'm in the hospital from about 7 in the morning till 7 o'clock at night. I'll have 4 to 12 patients who are admitted to the hospital that I see in the morning with my team. And then we make a plan for what's going to happen during the day. So sometimes kind of the most common things we see are people that get really bad blood pressure problems in pregnancy, something called preeclampsia. And so their blood pressure is too high to be outside of the hospital, but high enough, but not high enough that they need to be delivered. And so they'll be in the hospital for us to sort of watch them every day. And most of those patients are there for us to decide, do they need to be delivered, or can we sort of wait, or are they stable to go home? So the most common things we admit people for are high blood pressure in pregnancy or preeclampsia, premature labor, so people who are trying to deliver too early, or what's called preterm premature rupture of membranes. So a not insignificant portion of the population will have their bag of water break before their body is ready to go into labor and they're still premature. And those patients get managed in the hospital, not because they're really sick, but because you're worried that they might get an infection related to their water breaking early. So I round on those patients usually from about 7 in the morning until 10. Then, of course, we have to do our documentation because everything in medicine is documentation. If there's one thing I could tell all of you to take if you want to go to med school, take a keyboarding class. So I remember 1.5 million years ago, my mom, who had not gone to college but had been a secretary, said, you need to take this typing class. It was called typing. And I'm like, this is stupid. I don't need to know this. It was the best thing I ever did because I see so many people and if you're going to go into any kind of healthcare, spend so much time typing like this. And yes, some programs will allow you to use a verbal dictation program, but man, if you don't know how to type or keyboard, it's going to make your life difficult. And so I think that then we spent about an hour documenting. I'm looking at the heart rate monitoring of the patients in the hospital. I'm doing ultrasounds if they need them. And then a lot of it's just teaching. So I'll sit around with our students and say, hey, what do you know about this strange thing that my patient got admitted with? Okay, you don't know anything? Let's look it up and I'll have you give me a presentation tomorrow on that. Or, hey, do you know how to do this sort of surgical technique? Let's work on this. So it's that I think is probably the most fun part because you get to teach and then also you get to have students who say, oh, what is the most common cause of X, Y, or Z? And I'll have to say, I don't actually know. Let's look it up together. So you're not only teaching, you're also getting, it holds you accountable for getting to learn the whole time. And I'm just someone who loves to learn. So I enjoy that part as well. So that's sort of what I do. And I think that's nice because you don't get burned out. I've been very lucky having those different activities in the pandemic, allowed me to have a little bit of self-preservation, to be completely transparent. So we have seen patients with COVID in our clinics, but it's a very different environment. And then it would be, 7 days of caring for pregnant people who have COVID and other issues, and then kind of getting a break. So having that all those different activities to do helped me weather the pandemic so far better than I think if I would have been only on inpatient and had to see this day in and day out.
Also another question we get a lot is, since nowadays, this day and age, computers and machines have taken over so much, how have you seen computers and machines take over your job, and how do you see them take your job in the future? Not your job, but more incorporated into your job in the future.
Yeah. I mean, I hope eventually I'm going to have a robot scribe who just comes along and instead of us documenting medical notes, that it would be somebody who would almost be a transcript of your communication with the patient and the communication of rounds. I think that would actually make doctors enjoy medicine a lot more. In my specific field, the technology has only been beneficial because we have way better ultrasounds. We have better technology for, doing fetal surgery. We have better technology for looking at fetal heart rate monitoring. So for example, in labor, most people end up with getting heart rate monitoring of the baby. And it used to be, you could only see that in the room on this printed out paper, where now it's, you go in the workroom and all of the pregnant patients' heart rate monitors are on the wall and you can see them. If I have to go home for something, I can actually watch it from my house. So for obstetrics in particular, it's made it easier. I will say the downfall of technology for me has been all of the disinformation that patients get with access to technology and social media. And so I think that would be the hardest part for me, is constantly fighting, well, my friend had this cousin who knew this woman who had this thing in pregnancy, and therefore I want that for me. Or I don't think the test you did is right because I had another friend who had it and she had something different. So I think for what I do, it's actually made it better. And I think could do a little bit more. I can go through kind of the other questions that have come up. So what extracurriculars did you do in high school to get into medicine? That's a great question. I think the one thing that I did that probably doesn't exist, because again, I went to medical school like 100 years ago, almost, it seems like, was something called Medical Scholars. So there was a program in my community for people who didn't have a connection to healthcare, or didn't necessarily have family that could help, where they sort of introduced us to all of the different kinds of healthcare roles that you could have in a hospital or clinic. And so that for me really piqued my interest. I would say for things that I did in medical school or in undergrad, to get into it, I did research. I did research in a like ecology lab. So the only research that I had done before I came to medical school was looking at the foraging habits of kangaroo rats in the Sonoran Desert. And no, I wasn't in the Sonoran Desert doing it, but I learned how to do research techniques. So I did that. Trying to think what other things I had done. I didn't really do a lot specific for medical school. I did a lot of participation just in sort of like volunteer work. So just like volunteering for a group that raised money for Camp Heartland, which was a camp that's in Wisconsin, and then did some work for raising money for St. Jude's. Not a ton of medical school specific work. I think that it would be very different now getting into medical school. I think the big thing would be research and then looking for some sort of health-based participation. So even calling, every medical school has a free or student-run clinic, and calling as an undergrad student and saying, hey, do you have any volunteer roles that I could do in this? If there is a public health advocacy group in your community that you could work on. I think where I like to see people now is really understanding some of the barriers to equitable care that we have in healthcare. And I think we are finally starting to identify those at the medical school level. And I personally like to see students coming in from the medical school for our residency who have done work that's bettering the community. So whether that is through, helping, our, a new refugee community access healthcare. There are different navigator types of roles that you can work with, volunteering with a public health campaign on the importance of brushing your teeth. I'm just kind of thinking of some of the things that our medical students have done before. But things like that, that'll really help you come in and understand some of the social determinants of health. We know that it isn't just the individual that changes their outcome. It's what they look like. It's their zip code. And these are the realities of the horrible structure of healthcare right now. And there are a lot of opportunities to get involved in that as an undergrad, as a, before medical school. And I think the next one was, how did the dynamic of your hospital experience change during the pandemic? In other words, did COVID really impact your daily routine at the hospital? So COVID has really upended the medical system. So starting back in March, when we first shut down, our patients who come in often for something really scary. So, every day I'll see somebody who had an ultrasound with their regular OB that there's something really bad might be going on with their baby. And so usually we would try to have them bring in 1 or 2 support people with them. And as soon as March, April, patients couldn't bring anybody into the clinic with them. So they could bring their phone and we would let them FaceTime with somebody, but they would also FaceTime with me in a huge mask, a full face shield, and it would be hard for me to communicate with them. Then you bring in a patient who has the same condition, who doesn't speak English. It's not safe to have the interpreters in anymore. So you've got me on FaceTime with an iPad interpreter. And so it really made the patient experience horrible. And no, it wasn't making it horrible for me, other than I just couldn't provide patients with the quality and supportive care that I had. Every day we would have patients come in who had symptoms, and we would have to explain to them why they couldn't come in. They would be very angry. I need my ultrasound. Every day we would call patients who had symptoms and try to explain to them why it wasn't safe for them to come in. And it was just really scary. I mean, we had doctors in our group who got COVID. We had nurses in our group who got COVID because we didn't have the opportunity to be vaccinated. And then in the hospital, we had the same type of thing. So at first, we didn't have any medical students. We didn't have any residents who could participate in any of the care for COVID patients. So they're not even learning what to do because it's not safe to have them in the hospital. We had patients who were admitted for horrible things. Like I'd have a patient who was at risk of losing her baby at 21 weeks before it can survive. And we admit her to the hospital and say, okay, say goodbye to your partner. When you're going to deliver, we'll call and they can come in, but just for that part. And so it was truly isolating patients in the most horrific of circumstances. And you had to watch them be there by themselves. It was heartbreaking. So that was kind of the first half. And now the second part, we've kind of moved towards fighting the disinformation campaign. So I work in pregnancy, and only about 1 in 4 pregnant people is vaccinated for COVID. And there are many reasons for that. We didn't include pregnant people in the original studies. We originally didn't tell them to get vaccinated. We just said we support vaccination. And so a lot of people were just scared. And, they remember what happened, even though it wasn't true, that, oh, well, I heard that if people's kids get vaccinated, they could have autism. And now you're wanting me to get an experimental vaccine. So we had that, and we had that layered on top of communities that have been, horribly mistreated by the hospital system through systemic racism, through many other reasons, and then expecting a community that has gone through this to trust me to say, you need to take an experimental vaccine. So we're fighting against problems we've created ourselves, and then we're fighting against stuff that's just simply not true. And what we know now is that pregnant women or pregnant people who get COVID are 15 more times likely to be hospitalized. They're 14 times more likely to be admitted to the ICU, and they're at an increased risk of dying. And we also know that if they get vaccinated, the antibodies cross through the placenta and they cross through their breast milk. The virus doesn't cross, the vaccine doesn't cross, but they can protect their babies by getting vaccinated. We have 100,000 women that have been vaccinated. So I know this, and I know it's safe, but I'm fighting against valid concerns. And now the people come in that say, well, I read this article that my baby could have Down syndrome if I get vaccinated, or I know that you're just experimenting on me. I know that my immune system will fight this off. And every single day, I have at least 2, 3, 4 patients that I have to fight against this misinformation. And then I go to the hospital and I have to see pregnant people who are on a breathing tube. We've had pregnant people die, and none of them were vaccinated. So every day I'm pleading with patients, please, I just had a patient in the hospital who died, and she probably wouldn't have died if she'd been vaccinated. Please take the vaccine. And a lot of them simply say, yeah, I've done my own research, and I just really, I don't think that's true. So they're trusting me to tell them that their ultrasound finding, what their ultrasound shows, but they won't trust me on this. And I think as a doctor, to go through that every day is really exhausting. To have young kids at home who can't get vaccinated and be worried every day because I know that I'm vaccinated and I could still get it, that I could take it home to my child and they could get very sick. That part's been really hard. And I think added on top of that is the fact that you leave your job and you go out in the community. And I have neighbors who say, I don't think it's as bad as you're telling us it is. I don't see it. And no, many people have the privilege of not seeing what's going on. And I wish I were in that role where I could just say, I can choose not to worry about this, but I made a commitment to help people. And it's been very difficult to say, yes, I want to be a doctor. I want to care for people, but do I want to care for people at the expense of killing my child or killing my partner before they were vaccinated to help people? Is a job that important? And so I think that's been very challenging for me. Even harder than for me are emergency room doctors, internal medicine doctors in the intensive care unit, who see this every day. And you go out into a world where it's almost like a completely different community. You're like, how do you not know what's happening? So I think that part's been hard. What's gotten me through is I have 2 very close friends who work in the emergency room, and we just vent together and say, we'll get through this. But it's been very, very challenging. And then you add that on top of that, you have a whole generation of kids in med school who didn't get to see patients for a year. They just did online medical school learning. And I think that's been hard. What I'm really trying to do is establish with patients just sort of honesty. Yeah, we didn't know what was going on with the vaccine. And I couldn't recommend it to you before because I didn't have enough information, but I do have enough information. I really care about you, and I want you to get this vaccine because I want you to be healthy. And if they say no, I've taken a harm reduction approach, much like I do in addiction medicine. Because in addiction medicine, you have patients need treatment, but they're not ready, and you still want to care for them. So I say, okay, I need you to know that if something changes and you're ready for the vaccine, I'm here, and I'm not going to say I told you so. I'm not going to make you feel stupid for changing your mind, because we often make people in our society today, you're just not allowed to change your mind. And I say, can you do what things can we do to keep you safer? So if you work from home, can you stay at home? Can you make sure everyone around you is vaccinated? Can you not have a huge baby shower indoors with no masks? If somebody's sick, if somebody tells you they have a cold, can you stay away from them? And if you are sick, can you get tested as quickly as possible so that you can get it in for things like remdesivir, monoclonal antibodies, things that we know can help make that less severe. I think what I have learned both in my advocacy before the pandemic and in the pandemic itself, and I'm sure all of you see this, is there's so many people who will not believe this is real until someone in their family is very sick. And so telling stories, having people share their stories is what changes the narrative for a lot of those people who are vaccine hesitant. Yesterday, we had one of our nurses who had chosen to be vaccinated do sort of a town hall for the whole University of Minnesota health system. We're mandating vaccines starting next month. People are very worried about that. And she told her story about, I was scared to get vaccinated, and here's how it went. Here's how my pregnancy went. Here's how healthy my daughter is. And here's a picture of her. And I think when people can personalize that and not say, oh, that's just the medical system, that can help a lot. But if any of you have any other ideas, I think we are always happy, the healthcare system, to hear perspectives, especially, if you say, well, I've been around my family and here's what they think about and here's how it can change. Sharing that information anywhere you can will help us, I think, even on social media. So I think that's it. It's the only way we try to fight it, I think, is just constantly giving a counter narrative, escalating that narrative, being open to talking to people. That can be very hard, because if I post something, I will have 20 people write horrible things about me and one person who seems like they're open. And how do you not let those negative things? You're a horrible person. You're trying to kill pregnant people with the vaccine. How do you weed that out and focus in on the one person who's ready to hear what you want to say? I think how do you think this pandemic has changed the medical field? I think that we don't really know yet. I think there's some really positive things that have come out of the medical school curriculum. So things are more equitable. So you can do a lot of your learning remotely. So if there are people that have family at home, if there are people who, are working a job during medical school, having some of the stuff remote and recorded allows people to be more non-traditional. I think something that I really liked was we changed all of the medical school and residency interviews to virtual. And while that's true that it doesn't allow you to see the place, I loved when I was doing my residency interviews. I got to go, I got to go to Colorado, and I got to go to Maine, and I got to go to New Hampshire, all these places all over the country that I thought I might want to live. But that was really expensive, and I didn't have the money for that in medical school, and they didn't give me an extra loan to go to my interview. So I had to take out this extra loan to be able to fly to my med school interviews. And I appreciate that I had the privilege of being able to qualify for that loan. So I think that it has made people, the move to virtual has made it more equitable to accommodate interviews. Now that still is under the assumption that everybody has adequate Wi-Fi and their own device and all of that. And that still remains a problem. But I think that part's been made easier. I think that the biggest issue is that we are not proactively addressing the PTSD and the trauma that so many healthcare professionals have. We're seeing an uptake in suicide, and doctors and nurses in a lot of different roles in the healthcare profession. We're seeing a lot of people quit. So we have a significant healthcare shortage here in Minnesota. We have had to close operating rooms because we don't have enough operating room staff to run the operating rooms. We have to limit how many patients we see in my clinic because several of our ultrasound techs have quit because they just didn't want to do this anymore. And we haven't increased the funding and the emphasis on mental health. And we know, those of us who work in this field, that if somebody has trauma or somebody has, PTSD, you need to treat that early to get the best results. And when I hear emergency room docs saying, I can't sleep at night because I'm haunted by what I've seen, and their department isn't jumping in to say, we are going to give you a mental health professional, whether by phone, by computer, by text, I think we're going to have a big problem in the next 5 to 10 years where a lot of healthcare providers aren't going to be there for themselves and their families, and they're not going to be as inspiring of teachers as we would like to see. So I hope to see a pivot in the healthcare systems and the medical schools where they're attending to people, and not just the attending physicians, the medical students, the nurses, the people that are doing environmental services. So we have these individuals, when we had a mask shortage, we're asking to come in and clean the rooms after patients were there for not very much money, and to put their family and themselves in danger. So I think that there's a lot of work that has to be done, and some of that starts with funding mental health and prioritizing mental health for everybody in healthcare. Sorry, that was a really long thing. I'm very passionate about that, and I really want to thank all of you for providing me the space to introduce some of this to you today.
Oh, thank you so much. That was a really, I think, profound answer, because usually people tend to focus on like the bad stuff that's kind of happened with it, but noticing that it could lead to like potential change.
Yeah, I think it makes us question a lot of things. And here's another part that I thought was fantastic. So we, emphasize board scores less, because if you think about, so you have those, everybody has the people that they know, and you may be them, but I think if to understand that being able to easily pass like the SAT or the ACT or the test, the MCAT, to get into medical school, you have to have the time and the privilege to access those study materials, to have a place to study. And when you are cut off from going to med school based by an arbitrary score, that's just silly, because I would say a lot of our best residents were the ones with the lowest scores, and they were the ones where we looked at them as a person and not one arbitrary score. And we know that the structure of that testing process is not equitable. So I think when we decided, hey, we're not going to emphasize those scores anymore, yes, you still have to take the test. And I mean, I would love to see a different way of testing people's preparedness for med school. So that's another positive out of this, is we're going to focus on things that really matter, and not solely, and it's not to say if you're a good test taker, that's not a good thing. It is. I mean, obviously, way back when, that helped me get into medical school. But I think it's time to question, have the things we've been doing actually been training people the way that we want to be good healthcare professionals?
Okay, since time is kind of winding down, I'll kind of ask one last question. What has been kind of your most memorable patient experience, whether it was really positive or negative, kind of what made it kind of stick with you?
Yeah, so I have a patient that I still stay in touch with, who I saw many years ago, and she was diagnosed with a baby that had a lethal genetic condition, something called trisomy 13. And many people make many different choices in that scenario. And she and her family decided that she was going to carry the pregnancy to full term and deliver. And I diagnosed this very early, like 13 or 14 weeks. We did testing that confirmed it. And then I got to take care of her and her family through the entire journey. They had named their daughter, and got to be there for the delivery and see something that I might not have made those same decisions in my life. And I'm grateful I wasn't put in that situation. But to see what they did, having their other kids there to meet this child, and the memory boxes that they made, and then every year they would do, some sort of remembrance of that child's very short life, and I'll stick with me forever. And I've seen a lot of patients in that situation, and I think it's a privilege to be able to be there with people in these really tough situations, and getting to be there with her and her family will stick with me forever. I think I'm very grateful that I get to do that.
Thank you so much for coming and giving your answers and stories. It was really helpful, the inside of OBGYN and what you did. Thank you so much for taking your time and coming.
Absolutely. And I don't know if you want me to just give my email address quickly in case anyone has any questions, or if there's things that I can help with, or